anabolic effects. Is growth hormone an anabolic steroid? Is growth hormone an anabolic steroid? No, because you know all steroids have what in common? Yeah, they're derived from cholesterol. So, and I hear this on the sports radio broadcast all the time. The athlete was caught with the anabolic steroid growth hormone, and it's not an anabolic steroid. It is an anabolic agent, and you can see the number of things that it is touted to achieve, but it is not an anabolic steroid like testosterone or one of these testosterone precursors like androstenedione or some of the reproductive hormones we'll talk about later. So, with respect to these anabolic effects, we've indicated that growth hormone is essential for normal developmental elongation of the long bones, the diaphyses and the metaphyses of the long bones. We talked about the endochondral ossification before. In part because of the presence of receptors, growth hormone receptors, both on chondrocytes and on osteoblasts. And there seems to be an effect, again, on bone tissue, but primarily on the cartilaginous component of the long bone developmentally. And we'll come back to that when we talk about calcium regulation later. But growth hormone also promotes mineralization of bone, increases bone density. That's another reason, for example, that athletes might be inclined to take it. Again, hypertrophy of muscle tends to enhance that, or at least there's some evidence of that. Promotes lipolysis. If you're an athlete who wouldn't want less body fat, lipolysis means breakdown of fat. A lot of that fat may or may not be used for metabolic purposes. Protein synthesis, again, sort of linking to the hypertrophy there. Now, one of the pathologies that can be associated with elevated growth hormone in adulthood is something called visceromegaly, abnormal enlargement of the viscera. And sometimes this is what proves fatal, not always, but sometimes this is what proves fatal in pituitary giants. What are pituitary giants? These are individuals who have, we saw the video earlier, the animation, pituitary tumor. Remember we said there are 3 general causes of endocrine pathology. What were they? You remember? Hypersecretion, hyposecretion, and impaired receptor activity. All right. Pituitary tumor could result in upregulation, elevated activity of those somatotropes. Somatotropes are the cells of the pituitary gland that crank out the growth hormone. And if the growth hormone levels are elevated in childhood, you get a child that's abnormally tall, usually. If the growth hormone levels persist into adulthood, you get something called acromegaly. Have you heard of acromegaly? Yes. What is that? Yeah, acro means distant, distal. The feet and the hands become abnormally large. You've probably seen the facial features of the individual with abnormally high growth hormone in adulthood. You get sort of a brow ridge, prognathous jaw, some other characteristics. But in any case, one of the less desirable features there are the growth of viscera. And again, sometimes the organs just become too large for the encasement in which they're contained. Now we'll talk about some of the metabolic effects later, especially as we talk about regulation of blood sugar by the pancreas. But growth hormone tends to elevate gluconeogenesis. I think we talked about this term before. What is gluconeogenesis? Let's see. Yeah, making of glucose from non-carbohydrate precursors, usually protein or fat. And of course, we talked about the performance uses of growth hormone. It's banned by the Olympic Committee and the NCAA. It can be difficult to detect in the urine, so blood tests are sometimes used. They're all kinds. It's like hackers and computer scientists. There's always a race to see who can prevail in getting the anabolic in the blood without being detected. Now, you don't need to worry too much about this table. This is a, if you look at the table here, it says clinical and biochemical characteristics of defects on the GH-IGF axis. What do we mean by the GH-IGF axis? Growth hormone, and what is IGF?
Inhibitor.
It's the insulin-like growth factor that's released from where? The liver. All right. So all this is a table suggesting some of the problems, and we don't need to worry about all of these, but this is a deficiency of growth hormone receptor. This is a binding protein. Remember we looked at that regulatory pathway earlier. This is an intracellular signaling pathway. This is another growth hormone carrier here. Here's the IGF-1 receptor. So what you'll notice as you look at the table is the height, and they're talking about standard deviation score down here. In all of these cases, what do you notice about the final height? Tends to be shorter than normal. So height is affected, especially with respect to parental height. And then there are a number of clinical features. So growth hormone can have, developmentally can have effects on other portions of the body. For example, we talked about mid-face hypoplasia, effects on the immune system developmentally, pulmonary stenosis, perhaps some mental issues, and so on, have effects on the reproductive physiology developmentally. So growth hormone is absolutely essential for normal growth and development across the board. And that was the only purpose. I just wanted you to see. Let's say that you have a growth hormone receptor problem. What would you expect to happen to IGF-1? Well, you can see it's diminished. There's insufficient growth hormone and the binding of the growth hormone. Either way, you're going to have insufficient release of IGF-1. And this is just to remind you of what? What are we looking at here? Remember the little video? This is, what is this? That's tyrosine kinase, right? And when we learn about tyrosine kinase, when they bind their hormone, they dimerize, and then they do this. They autophosphorylate, cross-phosphorylate, and that initiates that phosphorylation cascade. You can see I'm growing weary too. But this tyrosine kinase, remember the rule we learned, is used by virtually all growth factors, at least for our purposes in here, all growth factors, insulin, and I think in a modified form, growth hormone as well. So let's turn our attention to IGF-1. Remember, IGF-1 is responsible for the indirect effects of growth hormone. Growth hormone travels through the blood, travels down to the liver, binds to receptors on hepatocytes, in turn causing release of the peptide hormone, IGF-1, which, like growth hormone, is broadly anabolic. Again, anabolic means it's promoting growth, development, mitosis, and so on, even down to the cellular level. We say that it's insulin-like growth factor because it is structurally insulin-like and has some properties that have some metabolic properties in common with insulin. But here's what you need to notice over here on the right. It functionally behaves just like growth hormone. It binds to receptors in cartilage and bone and promotes both mitosis and cell differentiation developmentally. Now, GH, and I'm going to come back to this in a moment, as GH levels go up, what's going to happen to IGF levels? Go up. All right. We're going to qualify that in just a moment. Some types of malnutrition can inhibit release of IGFs. We saw in that table before that if there's a growth hormone receptor problem, that almost always diminishes release of growth hormone IGFs. Now, in your clinical literature, you're going to read, and this is going to be very important when you study the growth hormone IGF axis, that levels tend to vary directly with protein intake. So what does that mean? Somebody state that in simpler terms. The more protein you you eat, what should happen to IGF levels? They should go up. But in reality, that doesn't happen. So I'm just being a little vaguer here, and I'm saying they tend to very directly because one of the primary determinants of IGF concentration in the blood is insulin. And so it's really the relationship between protein and insulin that determines final IGF levels. So I just want you to make a note of that, and notice that depending on insulin levels, that will really determine the concentration of IGF in the blood. Now, we mentioned a moment ago the three general classes of endocrine pathology: hypersecretion, hyposecretion, and receptor issues. I think we pointed out that type 2 diabetes, receptor issue. Most all types of renal diabetes are receptor issue. And there's a special receptor deficiency disease called Laron's dwarfism. Laron's dwarfism. I can't say that for some reason. That results from inability of the receptor hormone complex to produce a normal biological response. There's something wrong with the signaling pathway.
So it's a receptor issue?
It's a receptor issue. Now, I guess, again, you can see I'm struggling for words here, but what I want you to understand is that in Laron dwarfism, would growth hormone levels be normal? Would IGF-1 levels be normal? What's wrong? What's the problem? Yeah, the receptor. There's either insufficiency of receptor or the receptor's there, but it's not signaling. The intracellular signaling pathway is deranged for some reason. And that's a common endocrine problem.
How would you test for that?
Yeah, well, this is a genetic problem. So one of your tip-offs would be you have a child presenting at an early age